So modern treatment of heart failure starts with some drugs that we've used for many years, but slightly updated. So we used to use drugs called ACE inhibitors, but now we have a modern version of this called sacubitril/valsartan, which is even better than ACE inhibitors in treating heart failure and reducing the risk of death for patients. We also use beta blockers, which have been around for a long time. But now we also tend to use two other drugs. The first we use is an MRA, which is a type of diuretic, but it particularly preserves potassium in the blood and therefore reduces the risk of heart arrhythmias and blocks the impact of one of the hormones that affects the kidneys. And then finally, we have the SGLT2 inhibitors like dapagliflozin that particularly seems to impact the export of glucose into the urine and probably has a very mild diuretic effect. All of these together dramatically reduce or improve the prognosis for patients with heart failure. Occasionally, we see some patients with a particular form of heart failure whose hearts go completely back to normal. This is particularly true in patients who do not have narrowings in the blood vessels that supply the heart, also called coronary artery disease, as the cause of their heart failure. Some of these patients will recover completely, but we often suggest that patients continue with their medication long term because about 1/3 of patients relapse when the medication is stopped. For other patients, the heart doesn't get completely better, but often the symptoms go and patients continue to feel very much better even though the heart is still not pumping very well. It's very important that patients don't have an excessive salt load. So eating high amounts of salt causes fluid retention, and that's the one thing that the heart and the kidneys really struggle with in heart failure. It causes fluid to accumulate, and then the patients can become breathless, and they can have swelling in the arms or in the legs or even in the abdomen. So controlling salt is the first thing that we need to be very mindful of in patients with heart failure. The second thing that we need to be aware of is controlling weight. The more weight you carry, the more difficult it is for the heart to function. For example, if you are 20 kilos over your ideal weight, you're asking the heart to effectively carry 20 bags of sugar that it wouldn't normally have to carry if you were an ideal weight. So I think that there's going to be some really exciting trials published for the GLP-1 agonists, which reduce weight. That's your Mounjaros and similar drugs. I think they will make a big difference to heart failure patients, and that will be proven over the next few years. But the SGLT2 inhibitors are particularly effective in improving symptoms and reducing admissions for patients with heart failure. There is also some evidence now that they improve prognosis, but they're not without risk. Patients who have a history of frequent urinary infections or thrush are advised usually not to take SGLT2 inhibitors because they increase the risk of infections in the skin, and they also increase the risk of urinary tract infections. The treatment of heart failure is always symptom directed, but sometimes we also have to think about the prognosis. If the heart does not recover, and often it doesn't, we need to think about reducing the risk of sudden death in patients with heart failure. And at that stage, we might suggest the implantation of a defibrillator. The defibrillator might be combined with a device, a pacemaker device, that helps to synchronize the heart. If the heart is pumping in a discoordinated way, we can tell that from the ECG. That particular device improves the efficiency of the heart and makes it pump more strongly. Finally, if at the end of that, the patient is still very symptomatic, then in a tiny minority of patients, we need to think about the implantation of a ventricular assist device or even a cardiac transplant.